Hello friends, I hope you all are doing great. In today's video, I am going to discuss a thrombocytopenia approach. Now first, we suspect a bleeding disorder with patients having following history like repeated episodes of bleeding, spontaneous bleeding or any type of trauma. Then we have first to look for the nature of the bleeding. It may be either hereditary or acquired, or maybe due to the platelet, or might be due to coagulation defect. Then we have to perform screening tests that I will discuss in further slides. Then after the result of the specific screening test, we have to go for some specific test to diagnose the condition. Here's the difference between the coagulation and the platelet or vascular disorder. First, the coagulation disorders, they are more commonly seen in male having positive family history, rarely present with the petechiae bleeding gums, like skin hemorrhage are large and few, deep hematoma common, and due to deep hematoma, diluted bleeding is also characteristic of this type of disorder. While the platelet or vascular disorder more commonly seen in female. They doesn't have a family history, often negative. Then the petechiae, bleeding gums, melena are the common complaints. Small and many skin hemorrhage is seen. Deep hematoma is not seen. That's why the diluted bleeding is also not seen. Now, as we have I have discussed the screening test and specific test. Screening test contains the CBC, peripheral blood smear, platelet count, bleeding time, platelet functional analyzer 100, clotting time, PT, Aptt, and TT. While the specific test contains the platelet aggregation study, factor assay, fibrinogen, FDP, D-dimer, platelet glycoprotein analysis. Now, first we suspect the bleeding disorder in the patients with having the platelet count less than 1.5 lakh, which is also known as the thrombocytopenia. Then we start with the basic studies like CBC and peripheral smear. The most common presentation or the pseudo thrombocytopenia might be due to platelet cytolysis. The first rule out this cause. Then if the platelet count is decreased with raised retic and cystocyte on smear, then look for the hemolytic condition. Then we further go for the coagulation profile, and if the coagulation profile is abnormal, it might be due to the DIC, and if it's normal, it might be due to the TTP or HUS. Now, the other conditions, if on peripheral smear we can see any abnormal cell, or CBC shows pancytopenia or isolated thrombocytopenia, we have to do further examination to rule out the causes, which is the bone marrow examination. On bone marrow examination, if the abnormal cells are seen, then it might be due to acute leukemia. Then if the pancytopenia, there are causes like bone marrow infiltration, aplastic anemia, hypersplenism. Or if any of all these causes are ruled out, then and the isolated thrombocytopenia is seen, we can think of ITP, or might be due to some drugs, myelosuppressive, immunosuppressive drugs, or some kind of infection that leads to isolated thrombocytopenia. Now, the prolonged bleeding time. As I have discussed, bleeding time is a screening test, not specific test. If the BT is prolonged, first look for the platelet count. If platelet count is normal or low. If the normal, it might be due to the von Willebrand disease, or platelet function disorder, or any kind of vascular disorder. But if the prolonged bleeding time and the decreased platelet count, go for the bone marrow examination and look for the megakaryocyte. If they are absent, they might be due to the decreased production of platelet. But if the megakaryocytes are normal or increased, it will suggest the increased destruction of platelet. Now, these are the coagulation pathways for PT and Aptt. So the factors which are included in these tests. So PT is for its extrinsic pathway. while APTT correlates with intrinsic pathway of coagulation. As we have to remember these things, it's very easy, as the PT only 2 letters, so smaller pathway, which is extrinsic pathway. APTT longer, so longer pathway, intrinsic pathway. Okay, now in PT the factors involved are the factor 7, calcium, and factor 10. Then we know the coagulation pathway, the prothrombin to thrombin, and thrombin converts fibrinogen to fibrin. While in APTT, as I have already told, it is a long pathway. It includes many coagulation factors, like it starts with 12, 11, 9, 10. Then the common pathway is there, the prothrombin to thrombin, and thrombin converts fibrinogen to fibrin. Now, if the APTT is prolonged, we further work up with the 50-50% of the normal and the patient's plasma. If the APTT is corrected, after adding the normal plasma, repeat the APTT after 2 hours of incubation. If it remains normal, we can conclude that there is the deficiency of coagulation factor. But if after 2 hours APTT is again raised, then it will use a factor 8 inhibitor is there in the patient. But if after the mixing study the APTT is not corrected, then we have to repeat the APTT after 2 hours of incubation again. And if it remains prolonged after 2 hours also, then it is due to the lupus inhibitor. Here we have to remember that the lupus inhibitor is the intermediate acting inhibitor. So after 2 hours APTT will remain prolonged, it not be corrected, while the factor 8 inhibitor is the time dependent inhibitor. So first, after the mixing, the APTT is corrected, but over the period of the time, this time dependent inhibitors again activates and it will prolong the APTT. Now, here is the complete flowchart for the bleeding disorder. As we first suspect the bleeding disorder, we go for some screening tests like bleeding time, platelet count, PT, and APTT. Depending on the result of these 4 tests, we have to decide whether there is a problem in primary homeostasis, secondary homeostasis, or the primary and secondary both homeostasis. If there is defect in primary homeostasis, in that the BT or bleeding time is abnormal, and or the platelet count is abnormal. If the platelet count is low, as it's simply we can conclude it as a thrombocytopenia. But if the bleeding time prolonged but platelet count remains normal, it might be due to the von Willebrand disease or the defective platelet function. Then, if the secondary hemostasis is affected, in that case the PT will be abnormal or the APTT will be abnormal. If PT is prolonged but APTT is normal, it might be due to anticoagulant, vitamin K deficiency, or factor 7 deficiency, as we seen in the PT or the extrinsic pathway. But if the PT is normal and APTT is prolonged, which is commonly seen in hemophilias like hemophilia A and B, the isolated increased APTT, or also seen in von Willebrand disease. If the PT and APTT both are prolonged, then it might be due to the liver disease, heparin therapy, vitamin K deficiency, or oral anticoagulant therapy. But if the defects lies in primary and secondary hemostasis both, then all the 4 parameters are abnormal. It is commonly seen in patients of DEIC and the liver disease.